Hello, Justin. My name is Allie. I'll be your nurse practitioner for today. I see in your illness questionnaire that you're here because of a new area of redness on your upper right chest that's not going away. I'm sorry to hear that this rash is bothering you. Before we get started, there are a few questions I'd like to ask you. Firstly, when did this rash start? How has it changed over time? And how does it feel to you now? These questions will help me to establish the rash's onset, duration, characteristics, and frequency of symptoms. I would like to know if there are any other locations of concern that you have today. What were you doing around the time that you developed this rash to give me an idea of possible activities that could have contributed to causing this rash? Are you aware of exposure to any infectious agents, toxic material, or known allergies that occurred around the time of the rash began? I would then ask if there are any aggravating or alleviating factors that have affected the rash and its symptoms. In terms of treatment, have you tried any medications or complementary alternative therapies at home that have or have not been working to minimize your rash's symptoms? A detailed physical exam starts by inspecting the rash itself for size, shape, configuration, color, texture, elevation, depression, and pedunculation. A well-lit room is important in allowing me to visualize the rash's distribution and characteristics. Another valuable way to assess a rash is by using palpation to assess consistency, turgor, temperature, mobility, and tenderness. If I am unsure of the diagnosis of a rash, simply by inspecting and palpating an area alone, then I would need to conduct further testing to rule out unlikely reasons for the rash. I can rule out a fungal infection like ringworm by using a potassium hydroxide scraping to look for hyphae and spores of the fungus under a microscope. If when I view this under the microscope I don't find any evidence of hyphae or spores, I can then do another scraping. This time I would add mineral oil to my scraping to see if I find any evidence of mites, such as sarcoptic scabiei. This is also called mange, and it's transmitted from human to human by direct and prolonged skin contact of family members or sexual partners who are infected with the mange mite. Without the aid of a microscope, they may only look like tiny black dots on the skin. However, when viewed under a microscope, mange mites should appear white in color, have an oval-shaped body, and 8 legs. If present on a slide, I should be able to see the female mite, her eggs, as well as fecal pellets. Pigmented lesions can be more clearly evaluated by the use of surface microscopy. This includes an illuminated 10 times magnifier, which can visualize the epidermal-dermal junctions and melanocytic activity. The mnemonic that is helpful in assessing pigmented lesions is known as A, B, C, D, E, where A is for asymmetry, B is for border irregularities, C is for color variegation, D is for diameter greater than 6 centimeters, and E is for the elevation or enlargement of the lesion itself. A more invasive test that can be used to evaluate a rash or lesion is a skin biopsy. Superficial skin biopsies are used on pedunculated, papular, or exophytic lesions. Peduncles are stalk-like growths, papules are small inflamed bumps on the skin, and exophytic means tending to grow outwards from the epithelium where it originates. A punch biopsy can identify tissues from the epidermis all the way down to the subcutaneous tissue layer. Excisional biopsies provide an even deeper specimen when it is desired to take a lesion out entirely from the skin surface. Based on my findings from inspection and palpation of your lesion, I believe that you could have a condition known as Pityriasis rosea, PR. PR is a common and mild form of a skin rash that is seen most often in children and young adults. The first signs of PR are the presentation of an oval patch on the chest, belly, or back. This patch is usually pink or tan in color. As it is the first lesion to appear, it is called a herald patch, until greater skin lesions begin to develop thereafter. Other signs of PR are fatigue, aches, pains, itching, sometimes severe itching, a cold, sore throat, or fever before even the rash develops. This lesion has what is called an annular arrangement pattern, which appears singular or in a ring shape. Many cutaneous systemic disorders present with annular skin lesions. This is why doing a physical examination and being familiar with the PR's clinical distinguishing features is so valuable for making a differential diagnosis. Most annular lesions are either asymptomatic or mildly to moderately itchy. If a patient reports a burning or painful sensation as well as itching, then a diagnosis of urticarial vasculitis should be considered instead. Physician and nurse practitioners diagnose PR mainly based on inspection, but can also utilize potassium hydroxide scrapings, anti-nuclear antibody testing, skin biopsy, zinc smears, direct fluorescent antibody preparations, viral cultures, PCR studies, throat cultures, rapid streptococcal antigen tests, and anti-streptolysin O antibody titers. Most treatment for PR is aimed at soothing the skin and relieving itchiness. This rash typically lasts from 1 to 3 months and luckily won't leave any permanent marks on your skin. Treatment can include corticosteroid creams or ointments, using moisturizer, and using mild Cetaphil or Aquanil soapless soaps instead of soap. Oral antihistamines may also be used to relieve itching. Avoid using any hot baths or saunas, which can dry out the skin and make itchiness worse. Thank you for coming in today. Give me a few minutes to come up with your treatment plan, and I'll be right back in to explain it to you. Thank you.